joining us. Today I have Dr. Lisa Guerra, who's with Breastlink Verity, and she's a breast surgeon, and we're going to talk a little bit about what the surgery entails. Well, thank you. Welcome.
Thank you for having me.
So let's talk a little bit about, first let's go into Breastlink itself and talk a little bit about what they provide that maybe some other surgery centers don't provide.
Sure. So Breastlink is a multidisciplinary group. We incorporate both breast surgical oncologists, dedicated breast surgeons, as well as medical oncologists that are dedicated to the care of breast issues as well.
Okay.
And we have relationships and partnerships with radiology as well as with plastic surgery. Okay. So most breast centers typically have surgeons and imaging capability, but we're able to incorporate some of the other disciplines that also help out with breast cancer care.
Okay, now we've talked to some other doctors that are Breastlink doctors, and the same thing, you know, you are a one-stop place. You can go from the very beginning of your diagnosis to the very end. There's just really something for everyone in all the stages of their breast cancer.
Yes, and you can kind of pick and choose what is necessary.
Okay.
Some individuals may only have an imaging need, whereas others may have surgical needs, may also need medical oncology care, and some are interested in that one-stop shopping. They want their imaging to be done and to see their surgeon and their medical oncologist and plastic surgeon all at the same time.
Well, the nice thing about that is that you have everything in one location. You don't have to ship anything off, so it's probably comforting to most people.
Absolutely, and certainly because we're all together, then the level of communication tends to be pretty quick, easy to find each other, and I think that that offers patients a lot of confidence within the group as well.
Okay. Before we started filming, you and I were talking about your history, and so you were a general surgeon before you became a breast surgeon. Tell me how the transition came about.
So typically for breast surgical training, you actually will start off with one particular discipline. Most commonly that is by being a general surgery resident to start off with. So basically after medical school you specialize in the practice of surgery.
Okay.
Most commonly that's a 5 to 7 year commitment. And during that time frame, you may have exposure to a variety of different surgeries. So you do kind of the general surgery work, bread and butter things, taking out an individual's appendix, gallbladder, colon, thyroid, but then you also incorporate some of the other disciplines, and that can include things like trauma surgery, transplant, pediatric surgery, vascular surgery, colorectal, plastic surgery. So a lot of different disciplines that all deal with surgical care.
Okay.
And then during that time frame, you might have the inclination that you'd like to specialize and focus on one particular area. Although surgical oncology is one of the options that you have with surgical training as well, I really wanted to dedicate my time and focus just to one particular area of the body, and that happened to be breast. So after completing my general surgery training, then I decided I would like to pursue breast fellowship training.
Okay.
And so typically for breast fellowship training, we might see general surgeons. I think that that's pretty much the bulk of the practice, but we also do see sometimes gynecology individuals, or individuals that are trained in obstetrics and gynecology that would like to have a focus on breast surgery as well.
Okay. Okay, and then how long did your fellowship last?
Typically, most practices are 1 year. In my case, I ended up doing 2-year fellowship program through the University of Southern California.
Okay, now you kind of answered the next question a little bit because you identified the difference between you being a general surgeon and then a breast dedicated surgeon. But maybe dive a little bit more into the true differences, because obviously breast cancer is a bit different than obviously the rest of the things you mentioned.
Right.
So tell me the difference.
So with general surgery training, as I made mention, you get a lot of exposure to different types of operations. Most general surgeons have certain things that they end up being really good at and like to focus their attention on, be that hernias, be that colon resections, be that thyroid cases, be that breast cases, or a combination of those, or emergency care. For breast-dedicated surgeons, most commonly nowadays they've done some form of breast fellowship training. And that incorporates other disciplines actually outside of surgical practice. So it includes things like radiology, pathology, medical oncology, radiation oncology, genetics, plastic surgery, so that you get a really well-rounded experience, and that's really helpful in being able to communicate to patients.
Right.
This is what you can expect moving forward. You have that opportunity to see those other disciplines in practice, learn more about them, and I think that that also is helpful for taking a patient through their journey in their breast cancer care.
So then your responsibilities don't just stop at removing the cancer. It stops at then it continues on to you do the mastectomy also, as well as the breast reconstruction. You do all of that?
So in some cases, we do oncoplastic surgery, where we're incorporating plastic surgery principles for especially the wound closure, along with oncologic principles. So trying to really take care of that cancer to the best of our capability, getting it out with a nice rim of normal tissue all the way around it, but also thinking about the aesthetic ramifications of what you're doing. So sometimes that will cause us to make a little bit of a different choice in our incision location. And in some cases, we will partner with plastic surgeons to do cases jointly. For instance, if someone has a breast size that will support them to have a breast lift or a breast reduction, we can use those types of incisions to not only take out their cancer, but ideally leave them with an aesthetic result that might be better than what they may have started off with. So it offers sometimes that silver lining, if you will, to an otherwise bad situation.
I see. Okay. Well, it's nice to know how that all operates, because you just never really know unless you ask.
Sure.
When you perform surgery, is it always necessary to remove the lymph nodes?
So typically we're removing lymph nodes in order to essentially stage an individual's breast cancer. So that would mean that lymph nodes may be required with removal for an individual that has a breast cancer. Most commonly that's for an invasive breast cancer, where breast cancer has gone outside of the confines of breast ducts or breast lobules and is into the surrounding tissue.
I see.
There are some select cases for an earlier form of breast cancer called ductal carcinoma in situ, where we may check up on lymph nodes as well. But it's most typical for individuals that have invasive breast cancer.
Okay, so it's not always necessary then?
Correct, and it's really, that information is used to help us make appropriate treatment decisions for them.
See. Okay, all right, good. And then what is the likelihood of a recurrence after surgery? Does that depend on the kind of cancer that they have?
It may depend in some respects on the type of cancer. More aggressive cancers we do tend to worry a little bit more about, particularly for breast cancer coming back at an earlier time frame. But in general, that difference may hinge really on the type of surgery that's performed. So for instance, for a mastectomy, where we're really trying to remove as much of the breast tissue as possible, the 12-year risk of breast cancer coming back in that same breast is typically quoted as being between 1 and 4%. So it's a low number, but it never goes down to 0. And then for individuals that may have a lumpectomy, some, but not all of those individuals may require radiation therapy as well. And their 12-year risk of breast cancer coming back may be anywhere from around 3%, or in some modern cases, sometimes they're even quoting lower risks for more favorable cancers, up to maybe 10 to 15%, depending again on that type of breast cancer.
Now you referenced 12 years. Why not 5 years? Why not 20 years? What's the mark there?
It just depends on the study. So for instance, some of the lumpectomy literature that's out currently has looked at 5-year data. And so with modern radiation therapy techniques, that 5-year risk of breast cancer coming back after lumpectomy and radiation has been quoted as being even as low as maybe 2 to 3%.
All right, excellent. Thank you for the clarification on that. Do you conduct genetic testing to identify a patient's risk?
It really depends on the individual situation. There are certain criteria that we may use to help and determine which are the individuals that we would really push a little bit more strongly to consider genetic testing.
Okay.
And typically that would include individuals who have been diagnosed with a breast cancer at a relatively young age, those that have been diagnosed at an age less than 45 to 50 or so, individuals who have had ovarian cancer at any age, an individual or family that's had both breast and ovarian cancer,
Okay.
a male patient or relative that's had breast cancer, an individual that's had breast cancer in both breasts or two separate, distinct, different breast cancers, even if they're in the same breast, or an individual of Ashkenazi Jewish descent with breast or ovarian cancer at any age.
Okay.
There are other criteria that are continuously coming out. So if there's a particular family that 3 individuals have had breast cancer, or if there's family history that might also include aggressive or metastatic prostate cancer, pancreatic cancer. So there's other criteria that may also be considered, but those are the typical ones that I would say that we go through.
Okay. Okay. And then in regards to treatments, you know, there's an awful lot of discussion about identifying what types of treatments without having a particular type of cocktail now. They're able to do a little more precision type of identification. What are you seeing on the horizon?
Well, I think that really kind of what we do in the here and now is that it's not cookie cutter medicine.
Right.
Not every individual is going to receive the same exact treatment. What's right for one may not be right for another.
Right.
So it really comes down to a variety of different features. What's the size of that individual's cancer? What type is it? What's the size of the individual's breasts? Do they have some personal preferences or family history aspects that we tie into things?
Okay.
And that, I think, has a lot of bearing on what we might do from a surgical standpoint.
Okay.
But as far as other treatment is concerned, although some is a little bit more standardized, for instance, in most individuals that have lumpectomies may require some form of radiation therapy. Not all, but some. And I'd say that there are also certain criteria for some of the medical treatments. If a cancer is fueled or fed by hormones, we may make recommendations for hormone blocking types of agents.
I see, right.
But as far as things like chemotherapy is concerned, nobody really wants to have chemotherapy, especially if it's not going to be very helpful for them.
Right.
And so there are genomic tests that look at the biology and behavior of that cancer to help and determine, is chemotherapy really going to be of benefit for that individual, or could it cause them more harm than good?
Right.
There are certain characteristics that would tell us, no, this is a cancer that really needs chemotherapy. But I'd say that there's a good number of those individuals that have particular types of cancers that may not always require chemotherapy. And so from that aspect of things, we are able to personalize their particular medical treatment depending on the biology of that individual's cancer.
Wow, so much goes into it.
Oh, yes.
You know, I know, and you're very, very smart on it, and you sound wonderful. And
Thank you.
I've heard some great things, and always great things about Breastlink. So
Well,
we
thank
appreciate you
very
being
much.
here.
Thank you for having me. Thank
All
you.
right. And thank you for joining us.